Hello, everybody. Thank you very much for spending your Saturday morning with us. So I'll just share the screen. So Arlene, there's a segment of the talk that's going to be interactive with the listeners. I can't bring up the chat for some reason. Would you be okay to just kind of call out what they're saying at that point?
Yes, we'll do.
That's grand. Thank you very much, Arlene. Right, so what we'll do, we're going to kind of discuss common questions around borreliosis and the challenges around diagnosis. And we'll start with the quiz. So if the poll could come up and answer it as best as you can. Alrighty, so I'll go through the answers with you. Fatalities have been reported, so that's true, the first question. The second, in Europe, late stage Lyme disease borreliosis typically causes Lyme arthritis. In Europe, actually, that one's false. It typically causes neurological symptoms, but there are no absolutes in medicine. Pre-pandemic, people used to travel quite frequently, so you'll still see it, but it's not necessarily the most common form. And then a negative lumbar puncture excludes a diagnosis of neurological Lyme disease. That is false, and all of you got that correct. So we'll close that. Now, this talk is going to be slightly different to what you may be used to. I'm not going to aim to kind of load you with information. The aim here is to basically spark something in you, spark an interest, spark areas of thought. As you've heard from the other talks, Lyme disease or borreliosis is quite a complex infection, and there's a lot to kind of discuss and a lot to learn around it. I'll start with an introduction to the spirochetal family tree over here, and up here you can see we've got syphilis, and over here we have the different branches of Borrelia. And then having a closer look, you can see that there's Bergdorferi over here next to the blue arrow, which is the testing which is most frequently done, and in the UK we do the antibody testing for Bergdorferi. But there are other branches of Borrelia which can also cause borreliosis or a clinical picture of what's commonly known as Lyme disease. So not always so straightforward. And one of the first common questions is why? Why is there so many varieties in terms of the presentation? And if you take a step back, and kind of look at infectious diseases as a whole, you realize actually this can be quite typical for many infections. Factors that impact on the presentation of disease can depend on the environmental factors, on the infection itself, how strong the infection is, what branch of the infection it may be, and on host factors such as their immune system, whether they were malnourished at the time, whether they were run down or tired, and other factors that can contribute. And, as an example, with polio, a lot of people automatically think paralysis, but when you kind of delve into the literature, you find actually somewhere between 90 to 95% of people who get polio are either asymptomatic or they get very minor symptoms, relatively speaking, so sore throat, fever, muscle aches. It's only 5 to 10% who have the neurological symptoms, and of that 5 to 10%, a proportion get better, and then a small proportion don't. And you've got a similar sort of a picture with TB as well. The majority get better, but you have a small proportion who have a very severe form of the disease. So that kind of gives you an inkling of things. And then a common statement is, well, this all seems quite recent. I've never heard of this before. And actually, when you delve into the history, like Anne has alluded to earlier, there's a long-standing history of borreliosis, particularly in Europe. Before it went by its American name in the 70s of Lyme disease, there was Banworth syndrome, which is a neurological depiction of Lyme disease. And in Europe, over the past century, there's been a long-standing link between tick bites and a disease or infection that will follow on from that. And then we've discussed transmission. There's no minimum proven time, and oftentimes those little ticks are so tiny that they can go unnoticed. So, a patient may not know if they've been bitten, and if they have been bitten, for how long it's been there for. So we can't depend on that in the history. And then you'll be thinking, okay, so that's a lot of information there. When should I personally be thinking about this? And as GPs, we'll probably have, you know, young, fit, active patients who rarely, if ever, attend the surgery. And then suddenly you've got a patient who you normally never see, and then suddenly you're seeing them fairly frequently, and they are ill, they're not well. There's lots of different things going on, and the whole watchful waiting thing doesn't seem to be working out. They just are evolving new symptoms, or they're deteriorating, and there's more than one thing going on. It's evolving, and there may be a background history, and it might be kind of months past where they'd spent some time in the outdoors. Particularly it's through spring and autumn, but not always. They may or may not have a history of the erythema migrans rash. It may be fleetingly present. It may only be present after they've had a hot shower, and then it will disappear again. And it's just that general picture that will kind of make you think, all right, this is a possibility. It might be worth having this on the differential. And as discussed earlier about the different stages of disease, where you can have early disseminated, and late. And in the early disease, within that first month, it can all be very non-specific. They might be a bit more tired than usual. They might be off their food, a bit of fever, sore throat. There might be an erythema migrans rash that's close to the original bite. Once you get beyond the first month, that's when typically you are likely to see the early disseminated form, and this is where it can occur in different organs. And while there are certain places which have a tendency to develop infection, it can go, you know, there's lots of histological evidence of it going to less typical places, like the spleen and the liver, for example. And so this is where I'm going to spree through the different types. You know, there's neuroborreliosis, where you've got sort of the facial palsies and meningitis. A patient might be presenting with difficulties with their balance, and it can mimic symptoms of other conditions as well, like neuropsychiatric illness, or Guillain-Barré or motor neuron disease. It can affect the joints and vessels, sometimes giving a picture of vasculitis. And CDC notes that it can give sort of a migratory muscular pain or tendon pain. And then in the skin, so when you kind of search for the erythema migrans rash online, oftentimes it's depicted in white skin, usually of kind of a northern European complexion. The thing with ticks is that they are very much equal opportunity beings. They will bite whoever comes their way, no matter the skin color. And unfortunately, there is a lack in the educational material of one, erythema migrans in its different forms. It's not always a bullseye rash, you know, sometimes it's a uniform rash, but also how it can look in different skin tones and different skin colors. And I've included a few examples here of darker skin. The other challenge is that cameras don't tend to be calibrated for diagnostic color accuracy. So what that can mean in real terms is that the redness or erythema or pinkness is toned down. And this is more apparent in non-white skin tones. A way of counteracting that, and since we're practicing during the pandemic, and we are often practicing telemedicine, ask the patient, the photograph isn't revealing any redness or erythema, but can you, with your naked eye, see any redness or erythema that isn't coming through on the photograph? Rachel's spoken about lymphocytoma. This is one of the more severe forms, but it can be more subtle than that. It can appear on the nipples as a swelling, or the lips, or the genitalia. And this example here is of acrodermatitis chronica atrophica, which is a late sign of late disseminated disease, and it's more common in Europe. And then briefly on Lyme Carditis, again, a variety of presentations. There is a reason why it's got the reputation as being the Great Imitator. It can present in a multitude of ways. There can be sort of a multitude of different types of arrhythmias that are appearing, and they might present with a pericarditis, myocarditis, or a combination picture. and there have been deaths. Frequently it's a posthumous diagnosis. There's a lot of debate in the literature about the prevalence, anywhere between 1% to up to 16%, particularly for sort of pericarditis, myocarditis picture. And there's some notes that it might be more, you know, the arrhythmias might be a more common form. And again, there's a lot of debate in the literature. Is this rare or is this underreported? Are we not noticing this? And we'll come back to this later in the talk when I talk a bit more depth about carditis and trying to problem solve your way through things. And often we feel a bit frustrated, a bit kind of down at heart, thinking, okay, well, how am I expected to figure this out? This is complicated. And this is where I put to you our training comes into play. There's the difference between somebody who's able to recite their times tables and somebody else who's able to take an equation and work it out from first principles. And, you know, the majority of time when we're practicing, it's about pattern recognition and sort of getting through, but sometimes the patterns don't fit. And that's a useful prompt to when we go back to first principles, go back to revisiting the history, looking at our differentials again, considering whether we need to review those differentials. Another thing is that what we often consider to be a rare diagnosis, when taken as a whole, may not be so. I was at an interesting talk a few years ago by someone who was working on the Genome Project, and there were two branches for that. One was for cancer, the other was for the rare illnesses. And something she said was quite striking, in that rare illnesses individually, yes, they're indeed rare, but when you take all the rare illnesses as a whole, they actually form much more of our practice than the common illnesses form. And often these patients who are kind of left with these rare illnesses, it can take on average about 7 years until they get a diagnosis. So there is something to be said for, you know, problem solving, for getting back to the basics of, you know, breaking down what the problem is and the bioscience, the basic biomedical sciences. And I've left a quote here from Carl Sagan, in that science is much more a way of thinking than it is a body of knowledge. It's about that skill set of problem solving. And sometimes you have to get out your inner Sherlock Holmes. And diagnosis does matter. If a patient receives a diagnosis, they then are online to be able to get appropriate treatment. They'll get the necessary support, be it in dietetic support or rehab, and other kind of factors as well, like if they're unable to work, ability to access kind of insurance and that kind of thing. And also they're given a chance at recovery. And there's an interesting definition for no man's land, in that it's a land that's unoccupied or is under dispute between parties who leave it unoccupied due to fear or uncertainty. And that can be quite a good description of what can happen in areas in medicine which are under dispute. And it's the patient who's caught in that no man's land, in that medical wilderness. And by not getting the diagnosis, they then aren't able to access the things that's possible when they do have a diagnosis. And it's just something to bear in mind. And as GPs, we have certain advantages. You know, disease sometimes can be local. You know, we'll see patterns happening sometimes before it's there in the official numbers. And we know our patients, we know who they are, we know our patch. We're generally quite good at the whole common sense, pragmatic approach and handling uncertainty and having kind of a working diagnosis and being willing to change that working diagnosis as new information comes to light, and just knowing when to hold that diagnosis lightly, knowing when to let it go, knowing when to rethink things. So we're going to have a little thought experiment. Now imagine, so the South Downs is, for those who don't know, a very beautiful stretch of countryside in southern England, and it's by the coast, you've got Beachy Head, and you're in a game show. And let's imagine that you've visited the South Downs many times, you've walked it, you know it well, and you're told in this game show that you have to get from point A to point B, and you've got the map to use. So you've got your map, you're blindfolded, and you're dropped off in a helicopter. As soon as that flies off, you take off the blindfold and you're focused. You're absolutely hyper-focused. You know your landscape. You open up the map to see the route they want you to take. You look at the landscape briefly. You're trying to find the markers. You're not finding it. This isn't making sense. You're not feeling comfortable. And you're noticing actually the sun's rather hot, and actually the sun, you know, it's all quite intense, and there's sand in your shoes, and there's a really strange sound that's coming from a nearby four-legged creature, and you have a closer look and you realize that's not a sheep, and this certainly isn't the South Downs, and you don't know where you are, but you know that this map is not going to help you. And sometimes it can feel like that in the consultation as well, where we have our guidelines and we're there in the landscape with the patient and it's just not matching. And there comes a point where you realize, okay, either the diagnosis isn't right, or perhaps I need to be looking beyond the guidelines. There's something more to this. So just kind of have that in mind. When you feel that sense that things aren't quite fitting, that could be a prompt to think further. And then just briefly, like, evidence-based medicine is fantastic, it's great, but it's not infallible. And you know, there's been a lot of focus over the years on being able to critically appraise a paper, but sometimes there's information that's beyond the paper that also needs to be appraised in order to uncover the problem. So I'm going to give briefly 3 examples, and I'd encourage you to, when you have some time, just have a look at these. One is Tuskegee. Some of you might be aware, and it's quite a toxic part of medical history. So originally in, I think it was the 1920s, a retrospective study was done on syphilis, where the study authors had gone through the histories of patients to kind of uncover the pattern of syphilis and its natural course. And bearing in mind, this was the pre-antibiotic age. And then a study group in Tuskegee thought, wait, hold on, why don't we do a prospective study? Now, the problem was, at that time, there were treatments for syphilis. Yes, it was the pre-antibiotic age, but there were treatments. And so they picked a population who were very poor, largely illiterate, and didn't have access to the public health messages that were going on at the time. They offered them free medical treatments. Well, it was a guise of free medical treatment. They didn't receive that. And they were basically kept, and they just watched the syphilis progress. It passed on to their partners. Children were born with congenital syphilis, and all in the name of the study. And they continued with that even when penicillin was there and understood as a good treatment. And this study ended in the 1970s when somebody whistle blew. So it's just to note that sometimes the ideal study isn't ethically the ideal thing to do. Particularly when there's other ways of finding that information. I'm sure many of you are aware of the opioid epidemic and the role of Purdue Pharma in their marketing, but also the way they use the medical literature to withhold certain information and push other narratives out. And I'd encourage you to read some of the investigative reporting around that. And then there's the bisphosphonate and research fraud. So there's a really nice piece of forensic statistics where they uncovered that some of the data in the original studies was fraudulent. But because they'd been there for so long, they're now kind of, that data is used in the meta-analysis, the conclusions are used in the guidelines, and it's very difficult to tease things out. So it's just, you know, acknowledging it's a great, EBM is fantastic, but it's not infallible, and it's important to kind of keep that kind of critical eye on things and looking wider. And just, again, as a separate thing, observation does matter. Like, we wouldn't have antibiotics if Alexander Fleming wasn't observant in his less than meticulous lab and didn't follow through that observation. And oftentimes, when you look at the history of medicine, you've got the eponymous conditions where they're very, very detailed observations on very few patients, like the Parkinson's essays, only on 6 cases. Wernicke's is only on 3 patients, and then he followed through with exploring the pathology when those 3 patients died. But they're very, very detailed studies. And what happens is that other people then pick up on those details. So, well, can I confirm this? Are we seeing this? And then you get the wider detail. So, in the age of mass data, there is something to be said for looking very closely at cases to kind of reveal truths that are transferable elsewhere, and having that scientific humility and being part of that picture of scientific progress. So this is the bit where we get interactive. So Arlene, are you with me?
I'm with you.
You're with me, grand. So audience, what I'd like you to do is have a look at this picture and tell me in the chat what you think is going on. Are people responding, Arlene?
So I'm not seeing anything in the chat yet. Okay, please.
Just revealed it. Okay.
Having a nap, sleeping, passed out after drinking, right. Dark doom and gloom, dogs lying on the floor, sleeping. Yeah.
So either sleeping or passed out after drinking. Right. So the accidental reveal. So he isn't passed out after drinking. This is a man who's basically been up all night sometime in the 1800s looking after his sick child with fever. He's come straight home from work, put his jacket on his child. The candle's been on all night. He's attended to the child with some food, picture books, and he's exhausted now, but the child is looking a bit better. And the idea I was trying to put across was that, in a consultation, sometimes not all the information is revealed. We don't necessarily have the full picture, yet we have to kind of make a working diagnosis and carry out management on that minimal information. And then as information comes to light, sometimes we have to change what we thought was going on. Like in other talks where I've done this, people have said it's a murder scene and other things. But it just goes to show, I hope, how strikingly our first impressions may not be correct, or they need to adapt as new information comes to light. So this is where I round back to Lyme Carditis. And there are a number of post-mortem case studies that have come from the CDC. And a lot of these cases, either there was an existing suspicion of Lyme disease when they were alive, or, and there's a case study of 3, I think from 2013, where they were all organ donors and there was no suspicion while the patients were alive. And these were all in their 20s and 30s. Some of them did not have an erythema migrans rash. And, one of them, I think, tested negative prior, I'll come back to that, but they didn't have the erythema migrans rash. And yet on autopsy, they had evidence of disseminated disease in multiple organs. And this young man, Joseph Valone, was 17 when he died. He was a very promising student, was planning and hoping to go to Brown University, spent a 2-week trip doing an environmental project. He came back home and he was unwell with flu-like symptoms, saw his pediatricians, told it was flu, continued to deteriorate the following week, saw them again, had blood tests including for Lyme disease. He continued to deteriorate, and then he collapsed on his mother's front garden, was unconscious, was taken to hospital and transferred to another unit when they noticed he was having arrhythmias, and then he died the following day. So 3 weeks after his initial symptoms. And when the autopsy was done on him, they found disseminated disease in his heart, in his lungs, and in other places too. And from these, there are a couple of points to take away. One, a person can die from disseminated disease and not have an erythema migrans rash. Joseph Valone had tested negative for Lyme disease before he died. So you can have a negative test and have disseminated disease that causes death. The other thing with Joseph Valone was that they also found Powassan virus, which is another tick-borne infection. So ticks are dirty. You can get more than one infection from a tick bite. A second gentleman here who unfortunately died last summer is Dr. Neil Spector, who was an oncologist over in Duke University in the States. And he's written very eloquently about his own personal experience with Lyme disease and then subsequently Lyme carditis, and the difficulty in getting treatment. His was so severe that he developed heart failure and required a heart transplant. And he's also kind of written quite eloquently about his frustration with the science around Lyme disease, in that he's used to a certain rigor with the oncology research, and he found that lacking in some of the research around borreliosis. I would encourage you to look up some of his interviews on YouTube or read some of his articles. And then, you know, you're not going to have a patient stagger into the room and say, you know, clearly this is a case of Lyme carditis. It doesn't present that way. They'll present undifferentiated. And I'm going to go a little more in depth, specifically on pericarditis. So in the European Society of Cardiology guidelines, it's very well written. And there's a very nice summary table where they kind of list the infectious and non-infectious causes, and you've got the bacterial section, and there Borrelia is mentioned. And it's, you know, once you get to the stage of complicated, complex pericarditis, it's useful having this in mind as a way to try and problem solve. Yet a lot of the summaries of guidelines that are available to us as kind of working clinicians are kind of summarized to the point where important information isn't included. They either focus on the first week or two of pericarditis, assuming things are resolved after, you know, use of colchicine. There's the assumption that it's viral or autoimmune, maybe TB, but there isn't mention of the other potential differentials or what we may need to do if it isn't getting better after that first week. And, you know, the ESC guidelines quite nicely kind of stresses the point that, you know, pericarditis is relatively common, but there's a lack of epidemiological data to be able to tease through this. And much of the information is based on kind of hospital admissions. And they also kind of stress that the causes are varied, and it depends on the locality, the clinical setting, the epidemiology. And my point is just to bear in mind that, you know, information can be lost in summarization. And sometimes in those summarized articles that we sometimes read, they can end up reading a little bit dogmatic as a result of that summarization. And sometimes we have to kind of go back. So I kind of was looking a little deeper around pericarditis, and I was looking specifically at this suggestion for colchicine. And then when you dig deep into the colchicine, into the ESC guidelines, that advice is based on 4 studies based in northern Italy, led by one man, Professor Amasio, who has done fantastic work. And where there's a lack of information of pericarditis, he's done very good work. But he's got very clear caveats that don't appear in our summary of the guidelines, in that if a patient's symptoms are not improving within 72 hours in a week with colchicine, the cause is not viral. You need to start actively seeking other causes, such as the bacterial. And, you know, by losing that information in the summary of the guidelines, you know, not everyone's going to head back to the European Society of Cardiology pericarditis guidelines to tease things out, not even the specialists. And so sometimes there's a risk that patients can be uninvestigated if it's always assumed to be viral, and there's a risk of deterioration. And pericarditis is a presentation, it's not the cause. And something that's worth mentioning from those organ donor studies where the patients had died, one of them, you know, the pathologist in Atlanta who was looking at what appeared to be a viral myocarditis, there was a strange appearance to it that he was familiar with from when he worked in New York, which is Lyme endemic. And he thought, okay, maybe this is Lyme carditis. And he did the very specific tests and staining, which then revealed it was indeed Lyme carditis. And then it appeared in the case studies. But if it'd been a different pathologist doing that study on the organ donor heart, if they hadn't have had that thought, could it be? If they hadn't recognized it's slightly different to the usual viral myocarditis, that's just another case that would have slipped and gone and wouldn't have been identified. Mentioning the guidelines, again, this is something that's lost in the summaries that we read. In the ESC guidelines, they're very clear that the use of steroids is an independent risk factor for recurrence of pericarditis. And they strongly suggest that it's avoided in infection, particularly bacterial and TB. But again, it doesn't filter through to the stuff that we have ready to hand in the front line. So things to think about. There's a couple of books which I would suggest. One is the book written by Neil Spector, and it's quite sentimentally written about his own journey through Lyme disease. Not related to Lyme at all, but My Stroke of Insight is written by a neuroanatomist who had a stroke, and it's about her personal journey through rehab and recovery and the challenges that are associated. And there are transferable lessons, whatever the illness. And Tope Sick by Beth Macy is a really nice piece of investigative journalism behind the opioid crisis and Purdue Pharma's role in that, but also the other elements that led to that. And then briefly, you know, once you've addressed the underlying infection, and that's a discussion of itself, even when they've been treated, there are consequences. You know, if a patient's lost weight, if they've lost 5%, they're at risk of protein malnutrition. If they've lost 20% of their weight, that's severe protein malnutrition. That needs addressing. They may have nutritional deficiencies, which, you know, there aren't good tests for all of them. There's no good test for a vitamin C deficiency. You're dependent on recognizing the signs, like the corkscrew hairs on the legs. And there are nice image pieces like on Medscape. In infection, try to avoid iron supplementation because that can drive the infective process. If someone's been very ill for a long period of time, they may have an element of an atraumatic brain injury. They might be having problems with balance, either because of a direct problem with their brain or the issue of having lost muscle mass while they're ill, and they may have widespread tendinopathies as they're trying to recover. And recovery is not a straightforward process. It's organic, it's not linear. There's an old Persian proverb, illness comes mountain by mountain, but leaves you hair by hair. And I think it describes quite well that it takes a long time. NASA did some very interesting studies where patients, well, not, they weren't patients, they were volunteers who were basically laid up in bed for periods of time to explore the effects of lack of gravity on muscle mass. And they found that for whatever period they were bedbound, it takes 2 to 3 times as long for them to recover back to baseline. And this is in healthy volunteers, not people who had a catabolic process attacking their body. So just bearing in mind of having realistic targets for your patients and not kind of expecting more than they're actually capable of doing. And the importance of pacing and recovery, like, you know, oftentimes these are motivated people, and letting them know that actually whatever you think you can do, halve it and just do that and listen to your body. Don't underestimate the challenges that's associated with healthcare bureaucracy, stigma, which Rachel has mentioned, that's associated with Lyme, that clinical error can happen. It can take a while before a diagnosis happens, and sometimes it can be entrenched, but no one's actually done the problem solving. And rehab at the right time in the right way, and if they're not recovering as you would expect, then again another prompt for problem solving. So history is really important. Do your clinical examination where you can and within the limits of, you know, what's going on currently. If the rash is present, you know, treat, but if it isn't, it doesn't rule out disease. Infection can present in a multitude of ways. Have an awareness of what's not immediately obvious to you or not immediately visible, that things can change. If you have that sense the map doesn't match the ground, it's the ground that you need to look at. Hold your working diagnosis lightly, and sometimes the evidential floor we walk on isn't quite as sturdy as we'd like it to be. So there are resources for patients online, the various Lyme disease charities, the toolkit, there's resources for doctors for further learning, and there's a lot of references. But that is the talk. So thank you very much for listening.